Picture this. You're flying down a rocky trail on your mountain bike, or, I don't know, maybe you're sprinting down the field in a high-stakes weekend soccer match.
Right, you're going all out.
Exactly. And then you clip a root or take a bad tackle, and you go down hard. All your momentum just drives your shoulder straight into the dirt, and you hear it.
Oh, that sound.
Yeah, that awful, sickening crack of the collarbone. It is an incredibly common scenario, and for active people, it is just an absolute nightmare.
It really is a visceral image, and, the biomechanics of that fall dictate exactly what breaks. When you land on the point of your shoulder like that, the impact travels straight down the clavicle.
So the bone basically acts like a shock absorber.
Exactly, yeah. The bone bows outward until it reaches its absolute breaking point, and then it just snaps.
So today, we are focusing specifically on mid-shaft clavicle fractures. That's a break right in the middle of the collarbone, And because of the way that force travels, these middle third breaks account for a massive 80% of all clavicle fractures.
Which is why...
It is. Like, if you break your collarbone, you are almost certainly dealing with this exact injury.
Right. And for this deep dive, we are exploring a massive paradigm shift in how surgeons put you back together.
Because it used to be so straightforward, right?
Oh, absolutely. The goal today is to look at how the medical consensus on treating this incredibly common injury has radically shifted. We're going to examine the surprising trade-offs between going under the knife versus just wearing a traditional sling.
And what that choice ultimately means for your body, your daily function, and, your lifestyle.
Exactly.
To get to the bottom of this, we are pulling from the latest and most rigorous literature available. We'll be looking at some major orthopedic meta-analyses, including a really comprehensive 2026 study by Hama and colleagues.
Right, and we're also bringing in foundational work by Wang and McKee.
Yeah, plus we're pulling insights from a highly detailed 2025 narrative review on clavicle non-unions by Jubal, and some sports medicine literature from Robertson detailing what it actually takes to get athletes back on the field.
It's a great stack of sources. But to truly understand where the medicine is now, we have to understand the dogma it's fighting against.
The old school way of thinking.
Right. For decades, if you walked into an ER holding your arm against your chest with a broken collarbone, the treatment was almost universally conservative. The doctor gave you a sling, told you to keep your arm still, and just sent you home to heal.
And the history behind that standard of care is wild. Back in the 1960s, there were these two large, highly influential case studies published by researchers named Neer and Lowe.
Yeah, those are the famous ones.
Their data established a medical belief system that basically went unchallenged for nearly half a century. They reported that conservatively managed clavicle fractures had a non-uni rate of less than 1%.
Which is an incredibly low failure rate. And that statistic became the gospel truth among trauma surgeons.
Just a total absolute.
Yeah, the prevailing motto essentially became a clavicle fracture heals with, without, or instead of medical treatment. The entire medical establishment operated on the assumption that the body would just magically bridge the gap on its own.
Okay, let's unpack this. Because if you actually think about the mechanics of the human shoulder, that assumption borders on magical thinking.
It really does.
The collarbone is the only bony strut connecting your arm to the rest of your skeleton. It is holding up the entire weight of your arm.
Right, gravity is constantly pulling on it.
Believing a completely displaced fracture will just heal in a sling is like assuming a snapped tree branch will perfectly glue itself back together if you just loosely tie it to the trunk while a windstorm is blowing.
That is a great way to picture it. And what's fascinating here is why those original 1960s studies were so wildly misleading.
Because they were definitely misleading.
Oh, completely. When modern researchers finally dug back into Neer and Lowe's patient cohorts, they discovered a massive flaw in the data pool. The vast majority of the patients in those historical case series were, well, they were children.
Oh, wow. That changes everything.
Exactly. Kids heal on a completely different biological level. They possess incredibly thick periosteum.
That's the vascularized membrane surrounding the bone.
Right, exactly. And their cellular turnover is highly aggressive. In a child, the bone simply refuses to stay broken. It aggressively seeks out the other side and bridges the gap.
So by mixing kids and adults together, they skewed everything.
Precisely. By mixing them in their data, Neer and Lowe completely mask the much poorer outcomes that adult patients were actually experiencing.
Yeah, and when modern researchers stripped the children out of the data and looked purely at adults, the reality was sobering. We look at rigorous systematic reviews, like the McKee meta-analysis from 2012 and the Wang study from 2015, and the numbers just shift dramatically.
They really do. It's night and day.
For adults, the non-union rate for non-operative treatment isn't less than 1%. It falls between 5 and 15%.
Which is a huge jump.
Yeah, and if the fracture is displaced, meaning the broken ends of the bone have completely drifted apart, the failure rate spikes even higher.
And you have to compare that to the modern operative data. Those same studies demonstrate that if you surgically intervene and stabilize the fracture, the non-union rate plummets to roughly 1.4%.
Wow, 1.4%.
Yeah, conservative therapy in a sling carries a non-union risk that is roughly 10 times higher than surgical treatment.
10 times higher. I mean, if the sling fails up to 15% of the time, the immediate question is who is holding that losing ticket. If you're sitting in the clinic looking at your x-ray, you need to know if your specific break is going to heal or if you are destined to become a statistic.
And that brings us to a fascinating clinical tool highlighted in the 2025 Jubal Review, known as Brinker's Table.
Sounds intense.
It essentially functions as a profile of mechanical doom. It calculates the risk of non-union under conservative treatment by looking at the specific morphology of the break and the biology of the patient.
So it's scoring the exact mechanics of the trauma. The major risk factors include, like, an initial shortening of the bone of more than 2 centimeters.
Right. Or having a comminuted fracture from a high-energy trauma.
So getting hit by a car on your bike rather than just tripping on a rug.
Exactly. The energy matters. And smoking is also a massive red flag for healing. But I think the demographic factors are what really stand out.
Yeah, what really jumped out at me were the demographic factor.
The Jubal Review pulls a staggering statistic from Brinker's Table to illustrate this. If you evaluate a 65-year-old female patient who comes in with a comminuted displaced fracture,
Meaning it's shattered and pulled apart.
right, her mathematical risk of non-union in a sling is 47%. It is virtually a coin toss on whether her collarbone will ever heal.
Wait, why does age and gender play such a massive, mathematically predictable role here? Is it purely down to bone density and osteoporosis, or is there a mechanical reason a woman faces a 37% risk?
That's a great question, and it's actually both. The biology and the mechanics actually compound each other. Bone density is a factor, yes, because the older body struggles to lay down robust biological scaffolding.
Right.
But there is a critical vascular component here, too. Women generally have smaller clavicle geometry. When that smaller bone shatters into multiple pieces, which is what comminuted means, the local blood supply is absolutely devastated.
Ah, so the blood can't get to the bone.
Exactly. The tiny blood vessels feeding the bone fragments are torn apart. If those fragments lose their blood flow and the patient's overall healing response is diminished by age, you get the perfect storm for a non-union.
We should probably define what a non-union actually looks and feels like for the patient, because it's so much worse than just a blurry x-ray.
It's agonizing.
The primary overarching symptom is severe, debilitating chronic pain. And the Jubal Review divides this failure into 2 distinct physical realities, right? The atrophic non-union and the hypertrophic non-union.
Yeah, so an atrophic non-union represents a total biological surrender. The bone fragments have been completely starved of blood. They lose all vitality. The bone ends begin to resorb and shrink, and the body simply stops trying to form a new bone callus.
It just gives up.
Exactly. Clinically, this manifests as a visible asymmetrical droop in the shoulder because the entire structural strut keeping the arm propped out from the chest has just collapsed.
Which sounds awful. But then the hypertrophic non-union is a totally different beast. That is a mechanical failure where the body is desperately trying to heal, but the environment is just too chaotic.
Right, the fracture is completely unstable, constantly shifting every time the patient breathes or moves their arm. Because the body cannot achieve stability, it panics.
It goes into overdrive.
Yeah, it continuously pumps massive amounts of connective tissue, cartilage, and immature bone at the gap, just trying to glue a moving target. This creates a massive, excessive callus bulge under the skin.
And that massive bulge isn't just an ugly cosmetic issue. It can become incredibly dangerous to the surrounding anatomy, can't it?
Oh, absolutely. The anatomy underneath the collarbone is prime real estate. A massive, unhealed hypertrophic callus sits directly above the thoracic outlet.
So it's pushing down on everything below it.
Right. This bony mass can physically crush the underlying structures, leading to a condition called thoracic outlet syndrome. The callus literally pinches the brachial plexus, which is the massive bundle of nerves running down into your arm.
Ouch.
Yeah, causing agonizing, radiating nerve pain and numbness. It can even compress the subclavian vein, creating severe vascular blockages and the risk of blood clots.
Here's where it gets really interesting. If leaving the bone alone carries a 50-50 failure rate for our hypothetical 65-year-old, and failure means living with a crushed nerve bundle, the logical leap is to surgically fix the bone.
Which is why the pendulum swung towards surgery. Surgical intervention fundamentally alters the biomechanical environment. And the sources discuss two primary surgical philosophies here.
Right, the nails versus the plates.
Exactly. There is elastic stable intramedullary nailing, or ES, where a flexible titanium nail is threaded directly through the hollow center canal of the bone.
Like a rod down the middle.
Yeah. And then there is open reduction and internal fixation, or ORF, which involves screwing a rigid titanium plate directly onto the outside surface of the bone.
The data from the Wang meta-analysis paints a very clear picture on which method wins out. Plate fixation is statistically far superior at reducing non-union risks compared to the intramedullary nails.
It just holds everything together better.
It makes sense mechanically. Putting a plate on the bone is like installing heavy-duty internal steel scaffolding, so a damaged building can safely reopen to the public while the cement is still drying inside the walls.
That's a perfect analogy, because a nail inside the bone struggles to control rotational forces the bone fragments can still twist around the nail. A plate locks everything down across multiple planes.
So nothing moves.
Nothing moves. The functional benefits of that rigid stability are profoundly clear in the McKee study. Operative treatment drops the non-union rate to that 1.4% mark, and it virtually eradicates symptomatic malunions.
That's huge.
It is. Out of 212 surgically treated patients in that trial, 0 experienced a symptomatic malunion. 0. In the non-operative group, 17 out of 200 patients did.
Wow. And you see that functional victory when researchers test the patient's actual quality of life. They use metrics like the constant and DA scoring systems.
Yes, those tests measure real-world shoulder function.
Right, things like overhead reach, the strength to lift a heavy box, or the ability to, wash your own back without pain. At the 1-year mark, surgically treated patients score significantly higher across the board.
And this functional superiority is really the driving force in sports medicine. The 2016 Robertson study makes it very clear that for athletic patients, an operative approach for displaced mid-shaft fractures is the gold standard.
Because they need to get back out there.
Exactly. It offers much higher rates of returning to their previous level of play and significantly faster return times. For an athlete, trading 12 weeks of atrophy and uncertain healing in a sling for a titanium plate that allows them to start physical therapy almost immediately.
It's a massive competitive advantage.
Huge advantage. Range of motion exercises can start so much sooner.
We have to pump the brakes slightly, though, because surgery introduces an entirely new category of problems. You are trading the risk of a non-union for the reality of living with metal hardware.
Yeah, that's the dark side of it. Surgery forces you to accept iatrogenic risks, which are complications caused by the medical treatment itself. Because the clavicle sits right under the skin, with very little fat or muscle to cushion it, patients frequently suffer from plate irritations.
Just feeling the metal through the skin.
Yeah, the metal rigidly grinds against the skin from the inside, especially when you're wearing a seatbelt or a heavy backpack. If an intramedullary nail is used, the insertion pin can protrude under the skin.
That sounds so uncomfortable.
It is. Ultimately, a large percentage of surgical patients end up going back into the operating room a year later for a second surgery, simply to have the painful hardware removed once the bone has fused.
And that physical reality transitions us perfectly into one of the most surprising and frankly deeply personal aspects of this deep dive. We've established that the titanium plate is mathematically superior for bone healing and athletic function.
Functionally, yes.
But fixing the bone is only half the battle. The patient still has to look at their shoulder in the mirror every single day, which brings us to the aesthetic dilemma.
And this is so often overlooked. Functional outcomes, like range of motion and grip strength, are constantly measured in clinical trials. But patient satisfaction with their actual physical appearance, the cosmetic result of the trauma, is rarely quantified.
Which is crazy because that matters to people.
Exactly. And this is where the 2026 HAMA meta-analysis becomes so crucial.
Yeah, when you look at the major Canadian Orthopedic Trauma Society trial, commonly referred to as the COTS trial, the patient satisfaction numbers are eye-opening. At 1 year post-injury, 84% of the surgically treated patients were satisfied with their appearance.
But in the sling group.
In the non-operative group, only 53% were happy with how they looked in the mirror. Nearly half were unhappy.
And the sources of their cosmetic dissatisfaction were completely polarized based on the path they chose. Non-operative treatment resulted entirely in deformity complaints.
Like the bump.
Yeah, a staggering 45% of the conservative patients complained of a highly visible, protruding bony bump on their collarbone where the fracture healed in a misaligned tent shape. Another 20% complained of a persistent droopy shoulder, which happens because the collarbone healed in a shortened position.
Which fundamentally alters the geometry of how their arm hangs off their torso. That makes perfect sense when you consider the biomechanics. Without the internal scaffolding of a plate, the bone simply fuses wherever gravity and muscle tension pull it.
Right.
But the patients who got the plate weren't universally thrilled either.
No, they weren't. Surgery simply trades the bone deformity for the realities of the scalpel. 5% of operative patients were dissatisfied with the visible surgical scar running across their chest. 18% complained of the visible implant irritating the skin.
And there was a nerve issue too, right?
Yeah, most surprisingly, nearly a third, 29%, reported permanent incisional numbness on their upper chest.
Oh, wow.
To screw the plate to the bone, the surgeon has to cut through the supraclavicular nerves in the skin, leaving a permanent patch of numbness below the collarbone.
But there is one massive demographic exception to everything we just talked about regarding cosmetics, right?
Yes, the adolescent exception. The HAMA meta-analysis highlights work by Reiser and colleagues demonstrating that for teenagers, conservative treatment in a sling is cosmetically superior to surgery.
Because their biology is still in overdrive.
Exactly. We mentioned earlier how aggressively children heal. Adolescents possess phenomenal bone remodeling capabilities. Following Wolff's law, their bones adapt to stress by constantly breaking down and rebuilding cellular structures.
So they just fix the bump themselves over time.
Yep. If a 14-year-old heals with a massive, ugly, bony bump, their body will naturally shave down that excess bone and reshape the collarbone to be perfectly smooth over the next few years.
That's incredible.
But a surgical scar, however, is permanent tissue damage. For young patients, patients yield a better mirror reflection than a scalpel.
So let me pose this directly to you, the listener. If you are the patient sitting in the doctor's office, how do you weigh the permanence of a surgical scar against the asymmetry of a droopy shoulder? It's a genuine aesthetic trade-off.
It really is. And if we connect this to the bigger picture, it proves that the best treatment is no longer just a mechanical orthopedic calculation. It is a mandatory shared decision-making process between doctor and patient.
Because different people care about different things.
Yeah. Precisely. A fashion model, an actor, or a competitive swimmer might desperately require biomechanical symmetry and willingly accept a fine surgical scar. Another patient might fiercely want to avoid an operating room and happily live with a visible bump on their collarbone.
Okay, but what happens when the worst-case scenario hits? Let's say you chose the sling, you accepted the risk of the bump, but months go by and the pain never stops. You've officially developed a symptomatic non-union.
The dreaded outcome.
Yeah. How do surgeons fix a bone that has completely given up?
Well, the salvage operations for midclavicular non-unions represent some of the most remarkable biological engineering in modern medicine.
It sounds like sci-fi.
It does. The 2025 Jubal Review lays out the protocol, but we have to start by acknowledging the stakes. Going in to surgically fix a non-union carries double the infection risk of fixing a fresh fracture.
Double the risk.
Yeah, because the local tissue is heavily scarred, the anatomy is distorted, and the blood supply is severely compromised.
So the surgeon isn't just fixing a break. They are resurrecting dead tissue.
Exactly. They have 3 absolute goals they must achieve in the OR. First, restore vitality, meaning they have to reintroduce a healthy blood supply and living cells to the dead bone fragments. Second, restore the physical length of the clavicle to correct the shoulder droop. And third, achieve stable osteosynthesis.
Which means locking the structure down so rigidly that the new biology isn't disrupted by, microscopic movements.
Right. And to restore that vitality, surgeons have to rob Peter to pay Paul.
I read this in the Jubal Review. It's intense.
The Jubal Review details how they harvest autologous bone grafts. They literally cut into your pelvis, harvest living, blood-rich bone chunks from your iliac crest, and tightly pack that healthy tissue into the dead gap in your collarbone.
Just to jumpstart the biological healing process.
Yeah, it's like importing a highly trained construction crew to an abandoned, unfunded job site.
Right.
But if the patient has a massive bone defect, like a huge gap between the unhealed bone ends, they have to deploy an advanced two-stage procedure called the mascolet technique.
So what does this all mean? The mechanics of this technique are absolutely mind-blowing. It involves tricking the body's immune system into building a custom biological greenhouse, just so the surgeon can plant new bone seeds inside it.
The biological manipulation is brilliant. In the first surgery, the surgeon cleans out all the dead, scarred tissue. They then take a specialized acrylic polymer called PMMA bone cement, mold it into a block, and wedge it into the empty bone gap.
And they just leave it there.
Yeah, this cement spacer is left inside the patient for 4 to 8 weeks.
So the body recognizes that acrylic cement as a foreign invader. But because the immune system can't destroy a block of solid plastic, its backup plan is to isolate it.
Exactly. The immune system aggressively walls off the PMMA cement by constructing a thick, highly vascularized pseudosynovial membrane completely enveloping the block.
Like a protective bubble.
Right. Once that membrane is fully formed, the patient returns for a second surgery. The surgeon carefully slices open that newly formed membrane, pulls out the plastic cement block, and leaves behind a perfect, blood-rich biological chamber.
The greenhouse.
Yep. They then pack that empty chamber full of the pelvic bone graft and lock it all down with a heavy-duty plate. The membrane immediately feeds blood to the graft, massively accelerating the healing.
And mechanically, they take zero chances while that greenhouse goes to work. The Jubal review mentions using angle-stable plates that lock the screw heads directly into the plate itself, preventing any shifting.
The hardware is incredible.
Yeah, surgeons use specialized bending presses right in the operating room to custom contour the thick metal perfectly to the patient's unique anatomy. In extreme salvage cases where the bone quality is practically crumbling, they will even deploy double plating, screwing one plate onto the top of the clavicle and a second plate underneath the edge.
Creating a literal steel vise to guarantee absolute immobility. We've certainly traveled a long way from the 1960s advice of tying a sling around your neck and simply hoping for the best.
We really have. We have covered some serious ground today. We started by dismantling the decades-old myth that every collarbone magically heals on its own. We dove into Brinker's risk table, unpacking how the severity of the break, your age, and your gender mathematically map out your risk of a painful non-union.
We really went through it all.
Yeah. We explored the undeniable functional supremacy of a titanium plate, especially for athletes trying to get back on the field. We waded through the highly personal, aesthetic trade-off of choosing between a surgical scar and a droopy, bumpy shoulder. And finally, we looked at the extreme biological manipulation of the mascolet technique used to rescue a bone that refuses to heal.
Bringing this all back to you, the listener. Whether you are an aggressive weekend warrior, a high-level competitive athlete, or just someone who might one day trip awkwardly on an icy sidewalk.
Which happens to the best of us.
It does. This deep dive is a powerful reminder that medical consensus is constantly evolving. The best treatment is never a rigid, one-size-fits-all flowchart. It is a nuanced, highly customized decision dependent on your unique biology, your specific injury mechanics, and how you want to live your life.
The ultimate choice between the sling and the scalpel is yours, but now you actually understand the unseen biomechanics weighing on the scales.
And as we close, I want to leave you with a thought to mull over, looking toward the horizon of orthopedic technology. We discussed the massive downside of surgical hardware, the metal plates irritating the skin, the protruding pins, and the frustrating necessity of a second surgery just to extract the titanium.
This is the biggest drawback.
But researchers are currently developing high-strength internal plates and screws manufactured from bioabsorbable polymers and magnesium alloys.
Oh, wow.
Yeah, these materials lock the bone rigidly in place for a year and then slowly dissolve and resorb entirely into the body's natural system.
That is amazing.
Once that technology is perfected and widely available, will the entire scar versus bump and hardware removal debate simply vanish? Are we looking at a future where we achieve invisible, perfect healing without leaving a trace of metal behind?
It is an incredible thought, replacing permanent hardware with dissolving biological scaffolds. But for right now, the choices in the clinic are physical, and their consequences are permanent. So the next time you picture taking that nasty spill off the mountain bike, hitting the dirt, and hearing that sickening crack, at least you know exactly what kind of biological and mechanical journey your shoulder is about to embark on.